I'm from Gainesville, Florida, and I'll be presenting my project on the correlation of MRI-derived ADC values with Gleason score in prostate cancer. So as you well know, PIRAT scoring has been widely used to assess suspicious prostate lesions, but it is a qualitative means of assessing those lesions, and it can be susceptible to interviewer variability. On the other hand, apparent diffusion coefficient, ADC, a value that's derived from the diffusion-weighted image on MRIs, is a quantitative means of assessing tumor characterization. So in my project, we sought to assess the relationship between the minimum MRI-derived ADC values and Gleason score in prostate cancer. So in this Western IRB approved study, we assessed 181 lesions by manually tracing them on the MRI, and then finding the minimum ADC value and correlating it with its Gleason score. So as you can see here, there was a stepwise decrease in the ADC values as Gleason score increased. So for example, for the 4+ or 4 and above, the mean ADC value was 222, and a minimum ADC value, minimum ADC value is 222, and then for low-grade cancers, for example, 3+3, the mean minimum ADC values was in the 450s micrometers squared per second. So up here you can see an example of a trace lesion where we found that the minimum ADC value in that lesion was 373, and then the correlating Gleason score was 4+3 degrees. So this finding is so important because it can serve as a non-invasive biomarker to assess tumor aggressiveness. And not to mention, anybody can learn to read these MRIs, trace the prostate, and then find the minimum ADC at no cost to the patient or to you. You can find any free software. We use our MIM software. Other findings have validated these as well. They support it, and then we also need future studies to further validate these findings. Thank you. Any questions?
I have a question to you. First of all, who was reading the MRIs to detect the ADC value? Was it the radiologist or?
So the urologist taught myself and another student to read the MRIs, and so she began by tracing them, showing us how to do them, and then we continued to do all 181 lesions in 101 patients.
Okay, and you are saying it's a very nice study that low ADC correlates with a higher Gleason score, and that's actually based, like I think it's done biopsy-wise. The biopsy was done and showed that it's Gleason, whatever Gleason it is. Was the biopsy done MRI-guided biopsy,
yes,
like targeted lesion biopsy, or this is a Gleason score from a different lesion? Like
no, so it was MRI-guided biopsy, but we also, the way that we do the biopsy is we did the normal.
So but this Gleason score is actually from the lesion?
Yes, so like for F1, F2, F3, and then we, however, if there was a lesion that was, for example, 3+3, that was like the transitional zone, and then if there was F1, that was somewhere else, since it's prostate cancer multifocal, we would use those two as different, that's why you see more lesions than patients,
I have a small comment that I think it's a great paper, and I think it's a good start, especially for active surveillance patient. Imagine a patient that you already did a biopsy for and you're following him with MRI. It's a cheap tool and you're actually doing it for the patient. And if you're confirming that there is no upgrade of the disease over time, that's actually a good measure without needing to do more invasive procedures later on. I mean, we can skip biopsies.
Exactly, yes. Yeah. That's what's so amazing about this is that we can avoid, after a biopsy has already been done, we can, if they do another MRI, we can see the differences in the ADC, see if it's getting lower or see, exactly. Yes.
So I think that when you're obtaining an MRI, there's these B values. There's like a high level, like a high B value versus a standard B value. Do you know if that was standardized in this data set, or?
So every MRI is different. We use 2 MRIs. We use a 3 Tesla General Electric and then a 1.5 Siemens. So I'm not 100% sure what B value about super, but I know that your MRI is going to be different from the ADC values that I'm going to get from my MRI. So if you were to look at other papers, our ADC values actually look kind of low, but that's normal for our MRI scanners, and your MRI scanner, if you would want to repeat the study, would be a little bit different. So does that answer your question a little bit?
Yeah, I mean, the MRIs they're complicated. I didn't realize that like they scan these phantoms every so often in order to check all the values, and it does get really complicated. And I think obviously this is a great study and something to move forward, but I think reviewers, when you get into like a radiology realm, they're going to ask questions about those types of things, and obviously the radiologists are going to help with that.
Yes, yeah. We do have like MRI physicists that help us with this project, so I wish he was here to help you more with that question. But
Just a question. like I said, every MRI have calibrations.
Yes.
Everywhere is different for one. So in practice, like a real scenario.
Yes.
If you have to go forward with this project, the patients will be always in the same institution, correct?
I would hope so, yes. So to be able to use these values to,
What do you mean if the patient changes the MRI machine or it will be standardized? How we can standardize this?
That's a really good question. I would probably hope that it would either be the same MRI scanner or they would have to go from stage 1. They would
You have the same machine, the same protocol, the same calibrations.
Yes.
And
So
it's my information because I work in 2 hospitals, one through Tesla, another through Tesla, and the results always different.
yeah,
So
yeah.
the radiologists that say the man puts the calibration, the time, the weather, so
Yeah.
it's quite difficult for them.
Yes, it is, using 2 different MRIs. And I believe that's also part of the reason why ADC values isn't so well known already, and it isn't a standard of care to use, because it's hard to kind of make it so that everybody can, like this ADC value to this ADC value, because MRIs are so different.
But we have the protocol, at least in the future,
Yeah,
you
I
can
think
say
that-
this protocol for a pin and for another.
Yeah.
You can
I also think that the study, like, it's an eye-opener for the correlation itself, regardless of the numbers, the correlation that low ADC correlates with a higher Gleason score. So I think this would lead to further studies from different
Yes.
institutions.
Yes.
Yeah.
So I'm from India, and the place where I work, it's a teaching hospital, and one of my residents is doing a study on MRI-derived ADC values for renal masses. So he's doing for kidney tumors, and he is correlating the final histopathology and correlating with the pre-operative ADC values. We are just working on that also.
Yeah, that's really
So
interesting.
you're going to see it next year?
Yeah.
Thank you so much.